Good afternoon, everyone. I am Rahul Gosain,
And I'm Rohit Gosain.
and we are Oncology Brothers. Today, we're joined by Dr. Sapna Patel, who's a world renowned medical oncologist and the program director of Uveal melanoma and fellowship director of melanoma program at the MD Anderson Cancer Center. She's also the cruncher of the SWOG committee. In our discussion with Dr. Patel, we will be focusing on skin cancer related clinically relevant studies that were presented at ESMO 2022. Without further ado, let us welcome Dr. Patel.
Thank you guys so much for having me. It's my pleasure to be here.
Thank you so much, Dr. Patel, for being here and taking the time to go over these important studies with us today. Let's start off with our first study, SWOG 1801, looking at neoadjuvant and adjuvant pembrolizumab in resected stage 3, stage 4 melanoma patient population. You recently mentioned it's not only what you give, but when you give. Can you please walk us through this study design and its findings and how this should be implemented in our community practice?
Absolutely. So, SWOG S1801 was testing the hypothesis: does giving some therapy before surgery improve an immune response that translates into a survival benefit? In melanoma, adjuvant PD-1 is a standard of care for resected stage 3 to 4 melanoma. And so, what we did is we took the standard of care regimen of 18 cycles of adjuvant pembrolizumab and we broke it up. In the neoadjuvant arm of S1801, participants received 3 doses of pembrolizumab, 200 milligrams every 3 weeks, followed by surgery, followed by 15 doses of pembrolizumab. And in the adjuvant arm, it was the standard of care. It was surgery followed by 18 doses of flat dose pembrolizumab. Our primary endpoint was event-free survival, and that's a unique definition for neoadjuvant studies. Event-free survival counts events from the time of study enrollment. So anybody whose disease progressed before surgery, during the neoadjuvant period, after surgery, before beginning adjuvant therapy, and any toxicities that may have occurred during that period. And then RFS, recurrence free survival, that we're typically used to hearing in adjuvant studies, describes events from the initiation of adjuvant therapy. So melanoma recurrence or death. And so in S1801, event free survival included all 4 of those: events before surgery, events before adjuvant therapy, melanoma recurrence after adjuvant therapy, and death from any cause. So this study was powered for an event-free survival difference. And at a median follow-up of 14.7 months, what you see is that there was a statistically significant improvement in event-free survival in the neoadjuvant arm. And if you look at landmark 2-year event-free survival analysis, it was 72% in the neoadjuvant arm and 49% in the adjuvant. The hazard ratio here is 0.58 with a two-sided p-value of 0.004. So that means the participants in the neoadjuvant arm, from the time of study entry, basically any time along the way, are doing approximately 42% better than the same group of patients who received treatment in the adjuvant setting. Overall survival was not yet mature. There were only 36 events. So it's too soon to know if this neoadjuvant regimen improves survival in the long term, overall survival. And of course, there is not an adjuvant regimen to date in melanoma that improves overall survival.
Dr. Patel, given the profound EFS that we're seeing, do you think this is ready for prime time for me to implement this in my practice tomorrow?
Yeah, it's ready. It's ready to go. So the beauty of S1801, when you look at it, there is no increase or even decrease in cost. What happened in the neoadjuvant arm is that, well, actually, it just happened on the study, is that from the time of entry, you did not know which way your patient was going to get randomized. So you had to pre specify what was the type of surgery you would do for this patient tomorrow, right? And so, in that way, when the participants on the neoadjuvant arm had a decrease in their tumor burden, they didn't have less surgery. They had the surgery that they were initially going to have the whole time. So, S1801 is not a referendum on de-escalation of surgery. They got the exact same surgery, the exact same number of doses of pembrolizumab. So this is the same cost to insurance and third party and healthcare systems, national healthcare systems. This is the same cost on both study arms just given differently. That sequence, it's not what you give, it's when you give it. That sequence makes all the difference in the event-free survival for these patients. So it's ready.
Perfect. Thank you. So while we're on the topic of what to give and when to give, this leads us into the second study,
Yeah.
immune study. Here
Mhm.
we're looking at the combination of Nivo and Ipi in adjuvant settings. Can you please discuss this study and its findings?
This is resected stage 4 disease. So the participant currently has stage 4, no evidence of disease. Do you give therapy in this setting, in this sort of like new wave adjuvant setting? I'm obviously hesitating to call it neoadjuvant, but do you give therapy? And the answer is yes. So there were many adjuvant trials, S1404, Checkmate 238, even Checkmate 915, that enrolled resected stage 4 participants. But this was a study dedicated to only that patient population. And what they did was they randomized patients 1 to 1 to 1 to receive either Nivo plus Ipi at the kind of typical melanoma dosing that we're used to. Nivo 1 milligram per kilogram, Ipi 3 milligrams per kilogram. That combination every 3 weeks for 4 doses, followed by Nivo maintenance every 2 weeks, Nivo monotherapy, or essentially a placebo. It's not hard to believe, but both arms did better than placebo. But what they did in an exploratory analysis was they actually compared the nivolumab ipilimumab versus nivolumab arm. And nivolumab ipilimumab also does better than nivolumab alone if you are somebody who believes that, we're not always powered to make these comparisons that aren't designed from the get-go. But if you look, and you can look at the full study for details. The hazard ratio is quite nice for nivolumab plus ipi over nivo, and the confidence interval is quite tight. So, we don't have a lot of hesitation to say that it probably is the best option for resected stage 4. So, recurrence-free survival, we had already heard. We'd already heard about recurrence-free survival a few years ago. What we heard at this study was overall survival. And interestingly, overall survival, not as clear cut. The confidence intervals are greater than 1. Doing something is better than doing nothing, is what we can say. Is combination therapy going to improve your overall survival, just like we saw in S1801 single agent and like we've seen in the adjuvant setting? There are so many options for metastatic melanoma that it may be difficult to impart an overall survival benefit. There's an interesting subset finding in the ImmuNed study, and it's in the BRAF positive patients. The BRAF positive group of patients have a marked improvement with nivolumab plus ipilimumab over nivolumab and over placebo. So if you have a stage 4 NED patient with a BRAF mutation, this may also be ready for real world use, where you can confidently say, nivolumab plus ipilimumab in this setting for about a year is what they gave, can improve survival. So both recurrence free survival, or what should be, it's recurrence free here because it's the NED setting, but recurrence free and overall survival with combination therapy.
Thank you so much for going over the data, Dr. Patel. Given the data from SWOG 1801, where do you see ImmuNed fitting into your practice?
Okay. So
Sorry to put
now
you on the spot there.
it's such a good question, though, because 1801 included stage 4 NED patients. So I've been trying to think of the right way to think about this from an algebra sense. So 1801 for stage 4 NED, or stage 4 resectable, let's put it that way. For stage 4 resectable, neoadjuvant pembro is better than adjuvant pembro. Okay, cool. ImmuNed says for resected stage 4, adjuvant combo is better than adjuvant single. But now we're left with the question, would neoadjuvant single do better than adjuvant combo? We don't know. We don't know. So I think it gets I think if there's a patient in front of you and you sit with your surgeon and your surgeon says, I can resect that oligometastatic disease, then you guys can have this fun conversation of, should I give it 3 doses of single agent PD-1 then? Should I do that and then you go to surgery? Or do you want to take them to surgery now and then I'll get on the backside with some combination therapies? So that's my take.
Thank you. Now let us have a look at Succumbit study. We saw the data from Dream Sequence. Can you
Yeah.
please share how Succumbit reinforces our practice here?
Yeah. Okay. So, Succumbit is the idea for the BRAF positive melanoma patient. Can you get a little bit of both? Can you get some immunotherapy and targeted therapy? Why are we sort of forcing patients to choose? So, DreamSeq, like you're referencing, I think that's EA 6134. This established in the frontline metastatic setting that starting with immunotherapy first and switching to targeted therapy at progression has superior 2-year overall survival than starting with targeted therapy first and going to immunotherapy. That's the frontline setting. Great. But that is a switch at progression. So what Secombat said was, okay, we see that study and we're going to add an arm to it. We're going to say arm A, start with targeted therapy at progression, switch to combination immunotherapy. Arm B, start with combination immuno at progression, switch to targeted. But arm C, the sandwich arm as they call it, give 2 weeks of targeted therapy. Without progression, switch to immunotherapy, and then at progression, switch back to targeted therapy. So it's a targeted therapy bread sandwich, I guess is what we would say. And what we had heard previously is that there was some signal that that sandwich arm was doing just as well as the immunotherapy first arm. DreamSeq showed us that there was a portion of patients who start with immunotherapy first who unfortunately die very quickly. They died within a median of 6 weeks without ever making it to the switch of targeted therapy. And so, what you see with the Secombat study in some subset analysis is that patients with an elevated LDH, this may be the group of patients where sandwiching them does best. So, if you have a patient with metastatic melanoma, elevated LDH, consider with a BRAF mutation, consider starting with 8 weeks of targeted therapy, switching at 8 weeks to combination immuno, and then at progression, switching back to targeted therapy. And that's the group where the sandwich arm really has, they're the upper curve. Immunotherapy first also does well in that group of patients. They numerically are coming a little bit lower than the sandwich arm in terms of progression free survival. So, it's not statistically significant, the improvement in the sandwich arm, but it's the curve on top. What you see here in the total population study, progression free and overall survival, is that arm C, which is the red arm in the curve, that sandwich arm is doing just as well as the immunotherapy first arm in progression free survival, maybe not numerically quite as well in overall survival, but they are doing just as good with PFS. So this sandwich regimen gives us a clue. There is a melanoma population of patients who probably can dip into both drugs, not at progression, but at an early switch. And that subset analysis of elevated LDH may be pointing to exactly which population that is.
Dr. Patel, especially in community, if there is a selected group of patients that were hesitant to give a combo of IO
Mhm.
and BRAF group, in that setting, would you jump off starting off with BRAF MEK inhibitors and then giving single agent PD-L1 inhibitor? Or would you give single agent PD-L1 inhibitor in that settings and then switch them to targeted agents?
Oh boy. I mean, we might be in a slight data free zone there. So it depends on your comfort level. And I think it depends on the reason that combination immunotherapy is either feared or not well supported. Is it that they have some underlying comorbidity where toxicity could be an issue? Is it that you're worried that their disease is in such a bad state that it could progress? They could be one of these early progressors before they touch targeted therapy. If it's that you worry about their disease, then I would say start with targeted. Because we know that targeted therapy, within a week of being on a BRAF inhibitor, you have immune infiltration. Now, the issue is within a month of being on BRAF inhibitor, those T cells have left the tumor. Hopefully, they're going downstream to the lymph node to educate, and that's where they encounter PDL1 and so forth. So that's this idea of the early switch. And some of our early studies in melanoma did a switch or did added the immunotherapy at 2 weeks or 4 and 8 weeks. The problem with triple or PD-1 plus BRAF MEK is the toxicities can be quite overlapping. So if you're actually going to do a baton pass from starting with BRAF MEK, it's a little bit of gestalt, but then I think you have to see what does the disease look like at 8 weeks. If you have now normalized an LDH, if the sites of disease have gone down to less than 3 metastatic sites, you might be okay trying PD-1 alone. And of course, you could do that for a period of time. And then if they're progressing, you could consider adding combination to it. On the other hand, if you have a patient where toxicity is the concern, I'm a little worried about them. We have to admit to ourselves that PD-1 alone gives toxicity, that nivolumab relatlimab gives toxicity. So you may never feel comfortable reaching for nivolumab ipilimumab if toxicity is your issue. And then maybe there are some other options, PD-1 and radiation, PD-1 and intralesional, things like that.
Dr. Patel, first of all, thank you for bringing all these studies to our attention on social media and then taking the time to discuss all these practice-changing data with us today. Truly appreciate your help.
Oh, it's my pleasure. I mean, these three studies are really, they're ready to go. The Immuned study has been published in Lancet Oncology. So you have that in your tool belt if insurance says no, we don't. What's the evidence for giving somebody stage 4 NED therapy? You have published articles. 1801 will be published and will be included in NCCN guidelines shortly. And then Secombat, it will be published as well so that you can use those as tools to change your practice tomorrow.